Good evening, everyone, and welcome to the AMA WA webinar this evening. Not a word I'm particularly used to yet, but we'll get there in time. And we're very happy to have you here, as well as some great panelists in the form of Dr Amandeep Hansra and Dr Marcus Tan and Dr Simon Torvaldsen, who's just running a couple of minutes late. I'll tell you a bit about the speakers, first of all. Who we're very happy to have here. Dr Hansra is a practicing GP in Bondi, which I don't need to tell you is in Sydney, but it says that here. And she's a national expert in telemedicine. We're very happy to have her here to talk to us. She was 7 years as a senior medical advisor at Medibank, and in 2014 became the CMO and CEO of Telstra ReadyCare, and went on to become the Chief Medical Officer for Telstra Health. So she's clearly a force to be reckoned with in the digital health space, and she founded Creative Careers in Medicine, a network with now 7,000 doctors that has a strong focus on digital health and startups. And she's a consultant in that area and has done a fair bit of work for government on digital health review and is on a number of boards, as well as the being a clinical reference lead for the Australian Digital Health Agency. We also have Dr Marcus Tan, who's a UWA graduate, and he has an executive MBA from the Australian Graduate School of Management. He's an experienced GP and healthcare executive and a company director who's got 20 years of clinical and commercial experience. So he's got a really diverse career: health tech, investment, philanthropy. Founder CEO of Health Engine, which is now Australia's largest online healthcare marketplace. Millions of patients a year are connected to providers across the country, and the vision for that company is to be a globally leading platform that revolutionises the access and experience of healthcare for patients and providers. He's a fellow of the AICD and the Australian Institute of Management, and he's on lots of health and community bodies, including the AMA and WA, and he's an adjunct associate professor in health leadership and management at Curtin and a co-founder of the Meridian Global Foundation. He's also a trustee of Telehealth, the West Australian charity that raises money for children's research and treatment. And Dr Simon Torvaldsen, he's chair of the AMA WA Council of General Practice, studied med at UWA, 3 years at Fremantle Hospital, and then went on to do some palliative care, and then into general practice. And he's the owner, or one of the owners, of Third Avenue Surgery, and also does some work with Silver Chain. He's actively involved in aged care, and he spends a lot of time advising on healthcare policy at state and Commonwealth level. So the key areas that we're going to address, we'll ask Dr Hansra to lead us through. And I would encourage you all to type in your questions, and we'll get to as many of them as we can in the 1 hour that we have devoted this evening. So, Amandeep, I'll hand over to introduce the topics.
Great, thank you, Andrew, for that introduction, and thank you for having me. And it's great that we can use technology to speak across the country. Thank you for inviting me, even though I'm from Sydney. Don't hold that against me. So tonight we're going to talk a little bit about telehealth. So really we're going to look at telehealth through the lens of the COVID-19 pandemic. I don't think we've ever in the history of medicine had so much interest in telehealth, and obviously trying to reduce transmission, trying to still provide care for our patients, and trying to protect ourselves has really been the driving force behind the large-scale adoption of telehealth across the clinical workforce. So this isn't something that just affects us in general practice, but obviously all allied health specialists. There are so many things being done by telehealth, or have been done over the last month. Another sort of area in relation to the telehealth is really the Medicare, temporary Medicare item numbers. So we want to talk a little bit about those tonight. We want to talk a little bit about the appropriate use of telehealth. So some of the concerns that have come up in webinars that I've been doing across the last couple of weeks have been around medical legal risk and how safe telehealth is, and what's in scope, what's out of scope, when do you need to encourage a face-to-face consultation. I also want to talk about some of the technology questions, because everybody assumes telehealth is all about technology, but I think we will realise by the end of today's discussion that it's much broader than just the technology, but we will touch on that. And I think something that's really important for us as we're sort of getting to the other, well, you know, don't want to jinx this, but getting to the other side of this pandemic, as what does the future look like post-COVID? Everybody's been saying the way we deliver care will never be the same again. But what does that mean? And what do our panelists tonight think post-COVID telehealth might sort of land in? And is this something that is going to sustain itself and stick around for the long term? So what I'm going to do is just ask Marcus and Simon some questions first. And these are questions that have been informed by some of the questions that have come through from members. And then we will move across to sort of Q&A from anybody that's joined tonight. And as Andrew mentioned, just pop your questions in the side and we'll try and address them. Obviously, we may not get through all of them, but we will try our best. And if there's any left over, I'm sure you send them through to the AMA-WA team that they can address some of those that they have knowledge in and can assist with. So we don't have Simon yet, but I think Marcus, I would like to start with you, and I think you and I can certainly kick off this discussion. We've both actually known each other for many years, have crossed paths in the digital health world, and back when I said we were almost sort of black sheep, where doctors who did digital health were kind of strange, but now we're in demand. So Marcus, tell me a little bit about
We're still strange, Amandeep.
We're still strange. Okay, all right. But just tell me a little bit about what has happened for you. What have you seen during this pandemic? How's it sort of affected your day-to-day work? And you run basically a company that works in digital health, and telehealth is certainly part of what you do as well. But give us a little bit of a summary of how you've seen things pan out.
Yeah, so obviously depends on which day you're talking about. Most of my time nowadays is spent in sort of digital health with Health Engine, but and certainly from that perspective, I've kind of experienced the whole using video and remote working, because we've been working from home for a while now, like a couple of months now. So I kind of understand what that feels like. But most of our days, still helping clinics remain open and accessing patients. We've pivoted quite hard into telehealth only because that's really what's been required of us. Helping patients sort of find practices with that are offering telehealth is part of it, as well as helping practices fill their books with patients due to the drop in numbers and so on. But from a clinical perspective, funnily my clinic hasn't really seen much change, only because I guess I use telehealth a little bit, but not very much in my previous life anyway. And so I'm still relatively fully booked and seeing patients face to face. Just only because I've been in this clinic for a while, and I've got some pretty loyal patients that are willing to come in. And so a lot of triage for COVID and that sort of thing is actually happening in front desk. Obviously, there's clearly more use of PPE, and no one's sitting in the waiting room at the moment. So I'm pretty sure that's pretty reflective of a lot of GPs, particularly who are on the call, who probably feel the same way.
So what's sort of the split in your practice of telehealth versus face-to-face care?
Well, in our practice, it's probably not very much, because most of our practice is in things like skin and that sort of thing. So a lot of the examinations are obviously needing to be done in person. I can tell you a little bit about what we're seeing perhaps at the Health Engine level, because that's probably more broad. I'll focus a little bit more on GP, because that's probably where we're spending most of our time, even though we're helping sort of allied and dental and specialists as well. But basically, from what we're seeing, a lot of the telehealth appointments certainly that are being booked are being done via the phone, and a lot of practices are moving to telehealth. Like virtually all the practices are doing telehealth in some way, shape, or form, or at least trying to claim the Medicare item number when they are doing it. And so, from what we can tell, and this is actually probably a little bit different from some of our other tech company colleagues who are in that space, we're actually seeing about 65% of our telehealth being done via the phone. That is, 35% are actually done via video. And most of the video consults are actually being done by some of these sort of, consumer grade type of solutions like WhatsApp and Skype and FaceTime and these sorts of things, which are much more ubiquitously available, which is probably why people are using them. But what we are seeing is quite a lot of these people are actually quite interested in some of the more medical grade ones, because there are some concerns around security and and whether these sorts of consumer grade solutions are actually really fit for purpose in a healthcare setting. Even things like Zoom, obviously, who've actually, I've used a lot of Zoom in my sort of day to day with Health Engine, but I'm not sure I'd be using Zoom like at clinic level for various reasons, including security and other things which have been flagged previously. But there's just almost no need to. There are so many options now from a security, a secure video solution that's integrated into PMS and that sort of thing. There's so many of these things now that you almost don't need to use Zoom, and a lot of them are very cost effective. And just the other stuff that we're seeing is that about 85% of the consults we're seeing are telehealth consults are being bulk billed, in line with some of the new item numbers. And video has definitely seen a very slow uptake in GP. Like it's almost like begrudgingly being used. Nobody really wants to use video, from what I can tell.
Yeah, so that's interesting. I mean, our practice, we switched to a telehealth first model. So every patient essentially gets screened by telehealth in the first instance, and then we decide if there's somebody that we need to examine, and we bring them back in at a specific time. So, I mean, I'm seeing people do a whole sort of spectrum of different sort of arrangements, and there are others, and you said it can be reflective of the type of clinic you're running. So obviously in skin, you still need to see patients face to face. But and I did notice already that somebody was just asking about a proportion of GPs who might have gone 100% to telehealth. Have you seen any of that, Marcus, where people have gone 100% to telehealth and that they're not even open face to face, or sort of operating sort of completely virtually?
Yeah, 100%. So there are quite a few, well, I wouldn't say quite a few, but there are a substantial enough clinics that have actually shut their doors and actually just delivering all their care via telehealth. Now, that doesn't mean they're not at the clinic. They are at the clinic. It's just that they're not opening it for face-to-face because they're that paranoid. Now, my sense is that that's actually slowing down. I think a lot of people are starting to see that actually with the sort of reduced numbers and that, they're not as worried about spread. They're certainly not as paranoid about it as much anymore. They're actually opening up their doors and actually doing more face-to-face, which is, probably a sign of the times a little bit, which is obviously the worry for a lot of people as well. But there are certainly some clinics out of necessity in some cases where they aren't seeing, sort of face-to-face and have gone to 100% telehealth.
Thanks, Marcus. I might just use this opportunity to say welcome to Simon. Lovely to have you here. Andrew has already introduced you, given a bit of a background. So Simon, I'm going to throw you straight into it because we've missed having your input at the beginning. So we'd just like to hear from you. How has sort of the last sort of 2 months impacted you, and what have you seen from a day-to-day perspective, and specifically sort of in regards to the adoption of telehealth, and how's it impacted your work?
Well, thanks very much, everyone. My apologies for being late. And I think that in the beginning, the impact for us was very much organisational. It was really about screening, triaging, making sure that we had a safe environment. We changed the physical environment. It was about putting all the organisational structures in place to make a safe working environment for both our doctors and staff and for patients. And then over time, that's really transformed into actually making a practical delivery of healthcare and looking at where we integrate telehealth. I mean, certainly we were never at the point where we've screened everyone by a telehealth consultation before they came in. We had a triage system whereby our staff would do the triaging, and obviously the aim was to keep anyone out who was high risk. But we certainly said to our patients, if you need to just come and see us, we're open, it's business as usual. But if you don't actually need to see us face to face, then we have the option of telehealth. And certainly a lot of patients have found that very useful, and there's clearly a lot of stuff you can do with the without seeing the patient. But I think it's important to distinguish between those cases where the telehealth is adding to care and those cases where it's a poor substitute, and we're simply doing it because we think it might be safer.
So your patient cohort, Simon, I'm assuming are a bit older. Have you sort of found that there's been any challenges with them using telehealth? How have you found sort of the patient experience?
Well, I mean, we see all sorts. I mean, I've seen a lot of children today, but I also visit aged care facilities, and we deal with older patients, and we've really been doing phone consultations, and I don't think there's an awful lot of situations that I've come across where adding a video is really going to make a lot of difference. And in those situations, really the patient usually is just coming to see us. But a phone conversation with an elderly patient is quite straightforward. I mean, all my elderly patients, even the 90-year-olds, they've all got mobile phones. I think the challenges have probably been with those where English is a second language, or they've got speech or hearing difficulties. And for example, some of my older Italian patients just come in to see me, even if it's something that could be dealt with over the phone because it's just too hard. And these are not people who've got video conferencing facilities at home or even computers usually.
Yeah. So Marcus, many sort of doctors have struggled a little bit with the adaptation to telehealth and are concerned about some of the risks. And as Simon mentioned, sometimes there's that, concern that it's a poor substitute for face-to-face care. I mean, do you think that telehealth introduces new risks into clinical care? And, what sorts of things, have you come across or thought about that might mitigate some of those risks?
Yeah. I don't think that there are new risks. I know that there are new risks. I mean, it's very clear that there are new risks. But like all things, they can be managed. I think like most of these things, you've got to put the patient's safety, as a priority. I mean, it's not different really from any other face-to-face. The clinical governance of what we're used to is that has to be the paramount thing. But it does make it more awkward. So even things that you would almost just take for granted in your day-to-day sort of life, where especially if you know a lot of these patients, just the first risk is identification and then the first appearances of seeing that patient, right? I mean, in a lot of cases, especially in GP, you can quite easily tell whether somebody's either in distress or actually needing to be in emergency because they're really unwell the minute they walk in the door. It's not as easy to work that out when they're on the phone. Sometimes you can't even, if it's not a patient that's immediately familiar to you, trying to identify them is actually sometimes hard. So, there are all these little impediments that are not as obvious, when you first start telehealth, but then you start to go, oh, damn, you're right. Like, it's actually quite difficult. And clearly without the physical ability to lay hands, that's and even just doing routine office-based procedure investigations like urine dipsticks or finger prick tests and those sorts of things, the scope of what can be realistically done by telehealth is obviously less than what you can achieve when you're seeing somebody in a face-to-face, particularly in a practice setting. But irrespective of that, as I said, I think patient safety should still be a priority, and really it's the responsibility of GPs or the specialists or whoever to actually use their clinical judgment, obviously, to determine whether telehealth is really suitable for that patient at that time. But I think certainly from speaking to a lot of people who do telehealth and my own personal experience, I think the more experience you actually have with it, you can actually increase the scope of what can be safely managed by telehealth. And I think building the confidence with telehealth requires time to really establish your own kind of virtual consultation repertoire that minimizes those risks, right? And allows you to get the sufficient clinical information to allow you to have some sort of meaningful resolution of that patient's issues at the time. So one of the things I've sort of suggested to a lot of people who have asked me personally about how to manage telehealth is to actually start by creating a blacklist of issues that or requests or types of consultations that you just won't handle via telehealth, like won't do it remotely. So whether that's workers' comp staff or prescription of S8 drugs or any of those sorts of things, like you just kind of start with a blacklist that just allows you to say, nope, I'm not doing that. And over time, you might either add things on as you do more telehealth. You kind of go, actually, there's more and more stuff on this blacklist I just don't want to do anymore. This just makes me uncomfortable. Or you actually start removing stuff. You kind of go, actually, this is not so bad. Like, I can start to relax the blacklist a little bit because I'm actually feeling more comfortable doing that. But a lot of it's just knowing your limits. But that's not different from your face-to-face as well, right? So. Yeah, that's what I would do to mitigate. Yeah.
No, I think that's a really great approach, because I think it is about working within your scope, and we're used to doing that in general practice. We know what we need to refer on, and I think it's going to be the same with any mode of delivery of care. It's, you know, working out what can be managed, and sometimes it's working out what can be managed in the community versus what we send into the emergency departments. And it's the same here, what can be managed remotely and what needs to be seen face to face. And, you know, interestingly, there's international research shows that there's no worse outcomes from, you know, providing care via telehealth versus face-to-face care, as long as it's done within scope. But I think that's some of the things that people are grappling with, is how do you work out what the scope is? And sometimes you don't know until you start doing it. It's the first time you try to do an antenatal check via telehealth and you go, okay, that's one that we put on the list that we can't do. So I think that's a really good approach, is developing some policies in the practice about what can and can't be done. Now, Simon, I just want to shift the discussion a little bit to, you know, how we're funding all of this. So obviously a big driver for us adopting telehealth and being able to do it, you know, and some people will question this, but, you know, in a financially sustainable manner, is a temporary Medicare item numbers. So are you able to just summarise a little bit for us, you know, what are the changes and what are people able to bill now with telehealth?
Yes, well, look, now, I mean, there's a lot, and I probably won't even be able to remember the whole list, because there's an enormous list of temporary telehealth items. But the ones obviously that we use the most are the consultation items, and it's probably worth just putting forward this proposition that the intention of the government is that these items would mirror the equivalent face-to-face items. So, for example, the telehealth level B item is designed to mirror what you would otherwise do in a consultation, obviously with some of the caveats and restrictions that Marcus talks about, where you know, we can't do certain things without examining the patient. But the principle is the same. And we've now got, for example, care planning items, mental health items, and so forth as well, that can be done by telehealth. Some of these items are likely to remain in some form. The government ministers are quite pleased with their initiatives in telehealth, and I think that some of them will probably disappear. I think that some items and care planning and so forth, if it's possible, is probably better done face-to-face. But I think there'll be a review of the list of items and some decisions made by government about what's sustainable into the future and what's not. And certainly, I think a determination to bring telehealth back into the realm of the patient's normal GP.
So can you touch a little bit on the bulk billing situation, and because obviously that's changed a lot over the weeks, and where has it sort of now landed?
Yes, because this has been very fraught. From an AMA point of view, we've been opposed to any kind of restrictions on billing, and some of the restrictions that have been put on have been blatantly unfair. I've been certainly forced to bulk bill patients who have incomes far in excess of mine. So it's been a lot about politics and not an awful lot about need and looking after the disadvantaged. We have been able to get some concessions, and as everyone knows, the forced bulk billing has been wound back. We're now at the point where we're required to bulk bill children, card holders, and those who are deemed at high risk of COVID-19 complications. And there's a little list of chronic diseases and immunosuppression and pregnancy and so forth, some of which is pretty vague and woolly. I guess the carrot that the government's offered is that they've said, look, we're telling you you've got to bulk bill this, but we're going to double the bulk bill incentive. So we're now getting $12.75 for this instead of $6.40. So you could mount this argument to say, well, look, if Marcus says most of these items are bulk billed, and we're actually getting an extra $6 for every item. And remembering that this $6 goes on all the items that we are billing in the face-to-face consultations as well, overall, GPs are better off. And probably if we did a purely financial analysis, that might be the case. Having said that, it's a very bad precedent to set. And certainly most of us as GPs don't like being told how we should run our business. And certainly not something that I personally support going into the future.
So Simon, I mean, I've heard of practices that are feeling the strain because they've moved away from private billing. I mean, certainly at my practice, we were fully private billing and are now fully bulk billed, just because it was too hard to find that small cohort of patients that didn't fit into that vulnerable group. So have you seen that, you know, have you had any sort of, you know, practices that you've come across that have, you know, actually been financially impacted by this, or are you finding that that bulk billing incentive is really helping?
Look, there certainly are practices that have been badly impacted. I hear very loudly from them. And practices that are universally private billing are certainly going to feel the pinch. Our practice is largely private billing, and we have developed a model whereby some telehealth is bulk billed, some is privately billed at a lower rate, and some is privately billed at a higher rate. And I think it's about 50-50 with the bulk billing. But the government hasn't made it easy. I guess the difficulty is that they've adopted a one-size-fits-all approach. My suspicion, for what it's worth, and I'm happy to be corrected by those who have been more impacted, that probably not many practices are going to be bankrupted by having to bulk bill some telehealth. But certainly some of us have been forced to take a lesser income than we otherwise would. Some practices perhaps would be neutral, and some perhaps might, if you're a university bulk billing practice, you'd probably say you were advantaged. I think the difficulty is that the way it's been done is this one-size-fits-all approach that doesn't allow for individual circumstances and individual practices and their costs, and particularly smaller practices, those in the country areas, those who actually need to privately bill to be viable would be impacted, I think, more than some of the large corporates.
Yeah, and I guess some of the concerns, and I know from my practice, has been that if our patients get too comfortable with being bulk billed, how do we reintroduce fees at the end of this? I mean, do you have any advice, or do you have any thoughts about how practices might manage that, and whether you think that's going to be an issue?
I think potentially it is an issue, and all my doctors are busy telling the patients that this is sort of a special COVID thing and the government's put in these special item numbers, but that it's all going to come to an end in September, and it won't be bulk billed in the long term. And I think that what you say is a real risk. People get used to doing things a certain way, and if something's been free, you don't like paying for it. I think that's potentially a very difficult situation, and I think a lot of doctors also fear that it's the thin end of the wedge. I mean, if they can introduce it for this, what else? Is every new item that is put on the MBS going to be a bulk bill only item? I mean, where does it end? And I think that that's a real worry for a lot of us as well. And will it disappear in September is what a lot of doctors have been saying to me. What assurances do we have? So there's a lot of unanswered questions, and I think it creates anxiety in the minds of GPs, and I can understand that.
So, I mean, just talking about, I guess, you know, the financial side of telehealth. So Marcus, I just want to ask you this question. I mean, Simon has talked about using the phone, and that's, you know, predominantly how he's been delivering telehealth consults to his patients. And, you know, from the data that we can see, I've seen reports, and you mentioned 65% up to sort of, and I've seen reports of 80% of GPs sticking to the phone instead of, you know, implementing any video platforms. Can you tell us a little bit about, you know, if you're a GP and you are interested in sort of implementing technology for doing telehealth, what are some of the things that you need to be considering, you know, when you do engage a provider? And I think you started touching on some of the free platforms versus some of the paid, but, you know, what do they need to be looking out for?
Yeah, so I think a lot of it is just about making sure that it makes it fairly easy to adopt in terms of your workflows and other things, because I think that's the thing that most GPs are going to say, look, if it's too hard and I don't want to learn new tech or anything like that, if it's just too hard, I don't want to know about it. And I think that's very fair, and that's probably the reason why a phone, which is the easiest thing in the world, like it's a piece of tech that you've got that you're very used to using, that's, you know, and doesn't involve too much additional stuff. Well, that's obviously going to be the easiest to adopt. But when it comes to video, there's obviously other stuff, whether it's a webcam that you need to now introduce with a reasonable enough quality and resolution. I've actually been told that my, you know, camera for some reason or other isn't exactly giving the best resolution at the moment tonight. You know, if you can't actually deliver a good image, then what's the point, right? So you need to have the right equipment. When it comes to the actual services that give you sort of the video type of consultations, there are a whole bunch of them, and they're all much the same, but you've got to make sure that they're able to meet certain standards. So, you know, a lot of security and the ability to meet the sort of healthcare related type of standards involves making sure that, you know, that a lot of the sort of information that does pass through these sorts of services are, you know, the servers are in Australia, as an example. And that, you know, maybe, you know, it's hard to sometimes know, but, you know, being able to ask the service provider, look, you know, like, are your services actually, you know, all the data staying in Australia? The fact that it's end-to-end encrypted, you know, which effectively means that nobody can just jump into, you know, your consultation midway through, which is part of the problem with Zoom, was that people were able to just Zoom, what they call Zoom bomb, like, you know, and actually, you know, anytime, you know, could potentially interrupt that, you know, the consult was actually a concern. You know, you'll find that just little things that will make life a little bit harder, you know, are things that you probably need to think about. So things like, you know, whether they integrate into the PMS or your online booking system or any of these sorts of things, you know, it's very, very difficult if you've got to move between multiple systems or it doesn't actually get recorded in one place. That's certainly, you know, something to consider. And things like triage and the ability to take payment and that sort of stuff. I mean, you know, sort of Simon kind of referred to it, but, you know, it's just so much easier in some ways just to say, oh, I'm just going to bulk bill this, because taking payment, you know, having people write scraps of, you know, the sort of on scraps of paper, you know, credit card details and that sort of thing is not ideal at all. And certainly even if it's at the practice level, where the receptionist is actually trying to take payment after the consult, it's just not, you know, not an easy or, you know, sort of secure thing to do. So it's just finding ways of being able to improve that. And some of the systems, and Amanda, I know you're involved with CoView. CoView, like, you know, as a system, is a much more medical grade type of system that, you know, has all sorts of other bells and whistles that will, you know, that will actually appeal to a lot of healthcare providers. And that's something that, you know, that some people, if they're going to explore further into some of the medical grade sort of stuff, you know, you can actually get, you know, some of these better features as well. So, you know, so I think it is a matter of doing your research if you want to go further, but I can understand why people are struggling a little bit with some of the video stuff, because it's just a little bit more, you know, friction that maybe they just don't want to have to adopt.
It's interesting. You wonder if we could have been more ready. I guess these things have been around for a while, but we haven't felt a need to investigate video platforms or understand, you know, what might work with our other practice sort of technology. So, I mean, what do you think was sort of the reason for that, Marcus? I mean, why have we suddenly had to, you know, sort of rapidly advance and, you know, not really been in this space before?
Oh, look, you know, I mean, it's amazing what necessity and reimbursement does for adoption of anything, right? Like, you know, when your patients aren't willing to come in to see you, then you've got to find another way to get around it. Or if you're worried about patients coming in with, you know, and infecting other patients in your staff, like, you want to make sure that you can triage. And previously, I think one of the best things about this whole thing is that previously we were doing all of this for free. All the triaging was basically done for free. Anytime we did anything where, you know, it was on the phone, like give out people results, or even actually delivering a little bit of advice, because let's face it, patients will call you and do that. And it happens to me all the time. Like, you know, it's all done for free. It's all done for the love of it. In this situation, it is much easier, albeit, you know, you still have to make sure you meet all the criteria for it, to be able to now actually technically bill for it, which is actually sort of a good thing. And why I think that it's a good thing as a whole that the profession gets benefit of, and that it doesn't die after September. But we can talk a little bit more about that. And you know, like, I've got a few views on how I think it's going to play out.
So, Simon, I just wanted to ask you a question about some of the other sort of logistical issues. So what I've discovered is that, you know, it doesn't matter. I've got a video platform and I do all my consults by video, and I love it, and I enjoy it because I feel like it's a bit more social for me to be able to see my patients. But I understand that many people do phone. But one of the things that I've found are all the gaps in the other sort of digital health infrastructure that are missing. So obviously being able to prescribe, you know, electronic prescribing, which obviously hasn't sort of been taken up, hasn't sort of come into place yet. Being able to, you know, send electronic referrals, order pathology electronically. I mean, how have you been managing the logistics side of telehealth consults? Have you found that to be sort of a major pain point for you, or have you sort of managed to streamline that? Oh, we got you on mute.
We've managed, but I think it's an evolving situation, because gradually what we're finding is that there's more and more electronic solutions becoming available from our radiology and pathology providers, and so on. We've got electronic prescribing around the corner, and remembering that we do have now the ability for a prescription to be legally dispensed on the basis of an image, either email or on a mobile phone. But at some point the bit of paper has to be stored at the practice and so on. So it's a bit of a hybrid system. But remembering that if you get stuck, there's always the low-tech way of doing things. And I've, particularly early on in the piece, I mean, I'm still in the situation where I say to patients, well, look, I'll get the prescription sent and you've got another week left, so would you like me to post it to you? And we just are using snail mail to send that hard bit of paper until we have the electronic prescribing. Doctors are one of the few groups of people who still use fax machines.
I was going to say, is that one behind you? That's not a fax machine behind you now,
no,
is it?
No. Well, that's the multi-purpose everything.
Okay.
But it's and also I've had a lot of patients who've now we're getting a lot more email addresses than we used to, and so a lot of stuff is sent by email. So we've also got the ability to send referrals through resources like HealthLink. So I think, as Michael says, that the necessity has started to drive innovation. Up until very recently, there was no reason to. We weren't going to get paid for it. There was no business case for telehealth until a few weeks ago. So now there is, and we're actually developing the solutions as we go along. But there's always a solution. It's a question of, can we make a better and an easier and a more secure solution?
Yeah, so just, you know, on that point, I guess I'd be interested to sort of get both your views. So Greg Hunt said that we've progressed medicine more in 10 days than we had in 10 years. And obviously he's been a big advocate of telehealth and has been trying sort of the gently approach. And, you know, here it is now. Do you think that this is going to continue post-COVID? What's the world going to look like for us post-COVID? Has this fundamentally changed the way we deliver care? Or do you think it's going to be business as usual and we go back to where we were, as Harry Nesplin says, back in 2007? That's where he feels like we are digitally. What's your sort of views on the future? I'll go to you, Marcus, first.
Yeah, so look, sorry, can you hear me? Yeah. So yeah. Look, as I was saying, I think telehealth will be shown certainly over the next few months to the point of review that consumers will love it, right? And let's face it, Polly's love the fact that you know, they're doing something that consumers like, you know, alike. They're going to continue it, and this is kind of what we saw with some of the you know, sort of the at-home visiting services and these sorts of things, where, you know, like sometimes you would argue that the consumers loved it more than some of the providers actually delivering good care, right? So there was always that concern that sometimes, you know, you have these things, they're meant to be good in theory, and then, you know, people ruin it because they want to be too entrepreneurial, or they, you know, sort of start cutting corners and all those sorts of things. And I'm hoping that telehealth doesn't fall into that bucket, but there's always the risk and threat of that. And so I think that, you know, so long as it doesn't get abused. And you know, my suspicion is that consumers will like it. The polys will continue to fund it. What I think will happen though is that it'll change somewhat the whole mix of care that practices are currently delivering right now. So what I mean by that is that I think that the item numbers will become much more restricted than what it is now. It probably won't nearly be as free flowing as what we currently have. It will be probably attached to some sort of, you know, existing patient to an existing practice, that type of thing, so that you're not kind of just shopping around. The other aspect of it is that, you know, they'll probably, ironically, I think, try to increase the friction for the use of the telehealth item number and therefore require things like video as a thing, as a component of it, so that you're not just churning and burning on the phone, which is a very easy way of technically ramping up a whole bunch of items, you know, which I think they're going to want to try and discourage. And personally, you know, my take is that where we've seen this sort of two-tier you know, system where, you know, I think a lot of GPs would recognize that, you know, quite a few patients would almost have two different types of GPs. You know, the GPs that will, you know, bulk bill their repeat scripts and, you know, do the very transactional, very low value, you know, in their eyes, low value sort of stuff, and then sort of have their regular GP who is, you know, the one that will charge a little bit more, spend a little bit more time, and, like, you know, they'll want to do more of their complex stuff using that GP. I suspect that will equalize a little bit now. Like, you know, my feeling is that a lot of the GPs who are the sort of privately building or mixed building sort of practices will probably offer telehealth in a way to try and keep those patients from leaving to the, you know, down the road, you know, clinics that will just, you know, sort of churn their patients through. And we'll try and retain them using telehealth instead, because that's something now that they can get paid for and you know, and they can access. You know, so I think practices will evolve, and I suspect that probably that will mean that the universal bulk billing clinics who are currently in that model, and I'm not making any comments at all about the quality of care that they deliver, because I know a lot of these clinics deliver very good care, but they'll probably have to evolve their model as well, and they'll use telehealth probably, you know, in a different way. And a lot of these sorts of other sort of more corporatized telehealth type of services that don't offer the face-to-face sort of services will be the new de facto after-hours home visiting services type of services. You know, like they'll probably just be the after-hours type of services. That's the way I kind of think it'll probably play out.
Simon, do you agree? Do you see that vision that Marcus has?
I do, and I think that the fundamental thing is that telehealth is here to stay in some form. Because the people like it, you can't put the genie back in the bottle. And the minister is in fact very proud, as you said, of what he's done. The problem is that Treasury is extremely nervous, and there's going to have to be some restrictions, and it's going to need to be done in a sustainable way. And there's also already examples of, I think, what government and health departments and most of us would call inappropriate telehealth, and there will be a desire to clamp down on that. I think the principle will be that, as Marcus says, it will be linked in some way to the patient's regular GP. I think it's likely that patient registration, which was slated for the over 70s, put on hold for COVID, in fact, is likely to be brought forward. And instead of us having patients registered and being paid a lot of money to register a patient and doing the telehealth for nothing, which I have to say was among what was being pushed at one point, we're actually in a much better position, because now we've got telehealth, and we've got a reasonably good remuneration for it. I think that a lot of us would have said that it would have been introduced at a lower rate than a standard face-to-face consultation, but thanks to COVID, it's not. So I think it's going to be restricted to the usual GP, and I think that it will be ultimately something where it will be a patient who is registered to that GP, and instead of registration being telling us that we're going to do a whole bunch of stuff for nothing, it's now going to unlock access to these items where we're actually going to get paid on a fee-for-service basis. And I think overall that's a good thing. I think we've got to remember that telehealth has the potential, as Marcus says, for us to be paid for stuff that before we weren't paid for. And I think it's got a potential. We talked about the the risks, but it's actually got potential to make care safer. So, for example, when I give in the past, if someone's rung up for a repeat prescription, it used to be that my receptionist sent me a message. I looked at the patient notes and said, well, look, that's reasonable. The blood pressure last month was okay, and I'm happy to do a repeat prescription. But now I ring the patient up and actually check that that's really what they're taking, that their blood pressures are okay, and that there's no other questions. And we actually have a consultation instead of a Chinese whispers through my receptionist. It's safer, it's better. We charge $58 for that. The patient pays a $20 gap, and previously they paid $25. So I think we've got to recognise the benefits of telehealth, and it's an extension of normal care. It's not just a substitute. It's not just changing our consultation to suddenly all being online. We're now paid to do stuff that before either we didn't do or we did without getting paid for. So I actually think that the future is looking pretty good for general practice in that regard.
Well, it's great to hear both of you be quite positive about the future, and I really do hope that that's the case. We've had a few questions down in the panel that I just sort of wanted to address, and some of them have been answered, which is great. But somebody's asked, can you bill privately using the COVID item? Simon, do you know the answer to that question?
Yeah, you can. I mean, I think by saying using the COVID item, I think that they're probably talking about the telehealth. But if you are someone who's deemed to be at risk, and remember that this is something that is largely left to the GP to determine, and we've all got slightly different takes on this, the tricky thing being the chronic disease. I mean, eczema is a chronic disease, but it probably doesn't increase your risk of COVID. The department has really left it up to us to decide that, and we probably all adopted different approaches. My personal approach is that if someone has a chronic disease that does increase their risk of COVID, I think that the rules say that I should bulk bill those people. On the other hand, if they've got eczema or they might have had a puff of Ventolin 5 years ago, it's really making no difference to their risk, and I'm happy to bill those people privately. So we can bill those people privately who do not fall into the COVID high risk category. But if you're using that COVID, if you're using the telehealth item and you bulk bill, there's the COVID bulk bill incentive item that you can add on. But of course, you can only use that if you bulk bill. It's the COVID risk equivalent of a 10990 bulk bill incentive for a pension or a healthcare card holder.
Thanks, Simon. I think we've had a follow-up question. Is telehealth only for bulk billed consultations? I think you kind of answered that one, but what I think, if I interpret what you were saying, Simon, is that you can privately bill if people don't fall into that category of being into the vulnerable patient category, or they don't have a health care card, or they're not under 16. So it's really about finding those patients. So if you're somebody completely well who's not at risk of COVID and you want to privately bill them a telehealth appointment, you can. So I think that's that's pretty much where that answer is. So you can privately, yeah.
Yeah, I was just going to say that I think it's really important that people remember that it's the Medicare rebate is still the patient rebate, right? So you can bill whatever you want. Mm. The problem is that if you want to claim that particular item number, then unless the patient doesn't meet all the other criteria that requires you to bulk bill, then you actually technically can bill whatever you want. Even if it's a COVID high risk vulnerable patient, you can privately bill, but you just can't claim that item number. So ultimately, the patient won't get the benefit of that. They're entirely 100% out of pocket for it, which is part of the discriminatory aspect of this particular item number and its restrictions. And that's why probably a lot of, GPs particularly are saying, well, look, in some ways it doesn't really give us a lot of choice because, it's probably very discriminatory for these sorts of patients to have to pay 100% out of pocket. And so this is where, it's an issue, but technically you can bill whatever you want. Like, you just can't necessarily claim the item number if it doesn't meet the descriptor. That's the main, yeah.
And you can, and you might mislead your patients who think they can get money back from Medicare. So, yeah. Sorry, Simon, were you going to say something?
I was going to say that we had quite a discussion in our practice about privately billing telehealth, and we were very conscious of exactly what you were saying earlier, that we don't want to create an expectation amongst our patients that this service is going to be bulk billed and free to them ongoing into the future. And the philosophy that we ended up adopting was that, and this is personally what I do, is if it's something that previously I did for nothing, so if someone's ringing up simply to get a result or to ask me a question where previously I would have answered that for nothing and it only takes a minute or two, look, a lot of those consultations are bulk bill, and it's really on the basis that my patients previously were getting this for nothing, so they're likely to give me a hard time if they suddenly have to pay a fee for it. And I'm happy to take the $38 that I didn't get before. And as I was saying with the repeat prescriptions, where previously they paid a $25 fee, I think that if I charge an $80 fee and they're paying a $40 gap, they're going to say to me, well, look, guys, you're actually just putting your fees up. So we charge a lower rate for those consultations, and in fact, all the very brief consultations, because a lot of telehealth is fairly brief and straightforward. And if it's a consultation that only lasts a few minutes, we have a $58 fee so that they're paying a $20 gap. But if someone's taking a 15-minute plus consultation that is the exact equivalent of what we would have had face-to-face, then we're charging them $75 for that. And the exception being that if they fall into the vulnerable or disadvantaged categories that we are forced to bulk bill, we have to abide by the law, and we have to take that one on the chin at least until September.
Yeah, so it's quite complicated, and this is why I guess, like some practices like mine, we've just gone, okay, we're going to bulk bill everybody for now and deal with September when it comes. But interestingly, the number of gifts that have been sent to our practice has, increased significantly as our patients want to kind of pay us in some format. So lots of flowers and chocolates and all the rest of it. I'm not sure how safe that is during COVID, but we've appreciated that. But we're sort of getting towards the end of the session. But I just wanted to ask both of you if you had any sort of last comments or any last messages for the doctors out there, through this quite challenging time, I'd say, but also an exciting time where we're seeing the whole medical sort of profession be pushed into, the current day and sort of, adopting technology at such a rapid rate. But any sort of last words, Marcus, from you?
No, not really. I think, as we've kind of all been wrapping up and saying that, look, this is kind of here to stay, and I think it's worthwhile trying to get your heads around this a little bit more. Hopefully, and certainly, Simon and I have both been seeing how some of the policy sausage has been made around telehealth item numbers and that sort of thing through the AMA. They understand that there are, sort of complexities and the difficulty of some of the item numbers. I think they understand that. That, as Simon's saying, they are more worried about the fact that it's going to blow out, in terms of costs and that sort of thing. So they're trying to deal with the crisis and manage the finances all at the same time, which isn't the sort of ideal situation to be in. My feeling is that if people start to use telehealth and start to get more comfortable with it, it is something that they're going to, need going forward. So, better start now, especially given that there's some benefit to actually doing it now. The technology is actually not that hard. I know, most people, once they actually kind of get to use it, they kind of go, I don't know why people are so worried about this. It's actually pretty straightforward and easy. But I'm sure there's lots and lots of technology companies that are very happy, including ours, of course, but are very happy to, walk you through stuff because, it's not as bad as maybe it seems to them to start with. But yeah, look, hopefully people can stay positive and that, that people will start coming back, face to face, because that's not going to be replaced anytime soon.
Simon?
Yes, look, I think that's true. And I think that we can move forward with a positive frame of mind. here. This, if used properly, and if we play our cards right, if we at the AMA do our lobbying right, general practice is going to end up in a better place than it was before. We're not going to go back to as we were before, but at the same time, I don't think that it's going to be quite such the radical change that some, I guess, technophiles might say. I think that, as Marcus says, that there's a lot of value in face-to-face consulting, and I think that we will go back to a lot of that, but we'll go back to it with the option of telehealth as an add-on, and we'll all work out our own balance of, and our patients too. I mean, some patients don't want telehealth, they actually want to come and see me face-to-face. Others say, look, it's just great that you're able to do this without me having to come in. So it's about really the customer and providing what they want. One thing that I will say, perhaps a word of caution to those who overly embrace telehealth. One of the things that I have noticed in my looking at these things is that those practices which have relied really heavily on telehealth and perhaps discourage people from coming face to face, if you like, perhaps frighten them off, you could say, they seem to be the practices that are struggling a little bit more with reduced numbers. I think it's important that we introduce telehealth as an add-on and an extension of our normal practice. It's a value add to the patient. If we're frightening people off and giving them telehealth as a second-rate substitute, then patients are not stupid, they realise that. And I've had situations where, for example, ENT specialist who tried to diagnose a patient with earache by telehealth. And in true specialist fashion, he said, oh, I couldn't see in the ears, so I just sent them for a CT scan. But patients see through that. They see that as second-rate care. And if that's what we're doing, if we're saying to people, we don't want to see you, you're a danger to us, then I think that will not do your practice any good. I think that it's important that we say to people, look, we will see you, we want to see you, we want to give you the best care, and telehealth is sometimes a way of extending that care and making it better than it was before. And I think our patients will embrace that, and patients are already coming back to general practice. They're not going away, they need the care, and we just have to keep emphasising that and delivering the care, and I think we'll end up in a better place than we were before all this started. I'm not sure about the 10 years and 10 days, but we've certainly taken a much bigger leap forward through this crisis than we would have done without it. It would have taken many years to achieve what we've achieved now. So I think we should all be a little bit positive about where we might be heading, but we're not there yet.
Mm-hmm. No, I think that those are both of you made some really great points there, Marcus and Simon. And I think, you know, you're absolutely right. Our jobs, you know, are firmly secure. We're still going to have plenty of patients, and I actually dare say we'll probably have an influx post the pandemic when everybody decides to come and get their regular general practice things sorted too. So, you know, I understand that a lot of people are suffering at the moment financially with some of the impacts, but if they can weather the storm, I think we're coming out the other end. But I would like to say that, you know, in the future, I would love for us to not be having discussions about telehealth as much as I've enjoyed doing all these webinars and becoming very popular with my telehealth discussions. I would love that in the future, this is all just healthcare. You know, it doesn't matter how we deliver it. It doesn't matter whether it's a phone call, whether it's a video call, whether it's in person, it's all delivering healthcare. So I would like to say, you know, thank you for having me, inviting me to have this discussion with Marcus and Simon and AMAWA, and also for Andrew for his lovely introduction. I'm sorry, there's been so many questions down the side, and we've been attempting to answer them as we go along, but still, you know, send them through, and we will continue to answer those. If you will send you the contact details for AMAWA. And I think, yes, we will email people. And I think that's where we're going to wrap it up for tonight. So good luck with all of your telehealthing, and, you know, just stay strong. We're going to get out the other end, and I think the world is going to look a little bit better in, a month, 2 months from now.
Thanks, everyone. Good night.
Thank you.
Yeah, thanks very much indeed, everyone.